Thanks, Doctor.
Hello and welcome to our Google Hangout for Eliminating Trachoma MOOC. Today we're joined by Professor Alan Foster, who's seated right here next to me, and we're waiting for Dr. Anthony Solomon to join us and from Geneva in WHO. And due to some technical problems, we've had a small pause in trying to get him on board. And we have Dr. Paul Emerson. He is at an airport in Johannesburg, and he's going to try and join in from there. But to get us started, I guess, Alan, perhaps we could start by you telling us, how come you got involved in trachoma?
Thanks, Trachoma, and hello to everyone joining in. So when I was a young doctor, I always had the interest to go and work in Africa, and I had the opportunity to go to Tanzania, and I'd done some training in ophthalmology, fairly limited training, but knew something about ophthalmology. And when I went to Tanzania, I ended up working in central Tanzania near a town called Dodoma. And it was an area with severely endemic trachoma. So really, almost from the first week of being there, I was faced with lots of patients coming with inturned eyelashes, trichiasis and entropion. And so that was my first exposure to trachoma. And subsequently, I got more and more interested in it over the next 10 years.
Excellent. So over the last 3 weeks, while we've been doing this MOOC, we've had over 2,600 participants and from over 100 countries. And many of you have sent in a range of different questions. So to get us started, I think I'll just highlight some of the questions that they've started us off to while we wait for Saul to join us. So one of the questions that came up was, trachoma is an ocular infection. So why are we treating an ocular infection with a systemic antibiotic?
Okay, so if we kind of go back 15 years or so and look at what the recommended treatment for trachoma was at that time, it was a tetracycline eye ointment, and it was twice a day for 6 weeks. And it had been shown in various trials that were conducted in the 1970s that if you gave tetracycline ointment twice a day correctly for 6 weeks, then you did eliminate trachoma, chlamydia trachomatis agent from the eye. You treated the trachoma. The difficulty was putting that actually into practice in a public health program, because it meant one had to give out tubes of tetracycline to mothers and then show mothers how to treat their children. And the tubes of tetracycline, often in hot climates, as soon as you open them, all the ointment would flow out everywhere. It was messy, it was difficult, the children were small. So what all that came down to was, although theoretically and in a research situation ointment worked, in practice, compliance was poor, and it was difficult to make this ointment work. What then happened, I think in the early 1990s, it was work by Robin Bailey and David Maybe in the Gambia. They conducted a trial where they compared tetracycline with 1 dose of azithromycin given by mouth. Now, azithromycin at that time wasn't available as an ointment or as a drop. Hence, they used the systemic formulation and the pediatric formulation to go with it. And they basically showed that it was as effective as the ointment, even when the ointment was given perfectly. And of course, in a practical point of view, a one-time dose was much easier to get good compliance than 6 weeks of twice daily ointment. So that was really the study that showed a systemic treatment as a public health program would be better than the ointment. I should point out that in the meantime, drops are now available of Zithromax, and they are actually used for small children where you should not give the systemic treatment. But in the meantime, of course, a donation program has become available, and that's why the tablet is used. There is one other reason. I mean, that's the kind of practical reason of what happened. But the other reason is that in children who do have chlamydia trachomatis in the eye, they usually have chlamydia trachomatis in the nose and the ear. And in that sense, it's not just an ocular infection, it's elsewhere in the body as well.
The systemic one has many other beneficial benefits. So something else that has been repeatedly being raised during this period is the use of systemic antibiotics, of course, raises a concern for antibiotic resistance. And this remains a concern. So have we seen something on resistance with azithromycin? Right.
So there's two different parts one has to understand to this. First of all is we're using the azithromycin to treat chlamydia trachomatis. So the question is, does chlamydia trachomatis develop resistance? And the answer to that is there is, as far as I'm aware anyway, no evidence of that. And basically the macrolide group of antibiotics, which is tetracycline, erythromycin, and azithromycin is one of those, they have been used since the 1950s to treat chlamydia. And as far as we know, there's been no resistance. So I think we're on fairly safe ground to kind of say chlamydia develop resistance to the macrolides, including Zithromax. However, there's another side to this, which is used in the treatment of other infections, such as Streptococcus pneumoniae, etc. And therefore, would widespread use of azithromycin in a trachoma program pneumoniae? And I think in that situation, there is some evidence that does occur. I don't have all the kind of exact facts, but yes, other agents can develop resistance to azithromycin. Other bacteria can develop resistance to azithromycin. Whether the public health program against trachoma is encouraging that or not, we're not so sure. Right.
And we have to remember this is a single dose that we're talking about.
One time, single dose, yeah.
And in some places where you've only given the single dose, you're not even going back to give another dose unless the prevalence is high. So I guess this, we'll have to watch the evidence as it comes through.
It's certainly been looked at ever since the donation program started, which was around late 1990s. So I think if it was a problem, we would have seen it by now. And as I say,
well, we're still waiting to see if Dr. Solomon can join us. But just to keep the momentum going, we've got certain questions here on have you ever come across the idea of using anti-inflammatory treatment, such as topical steroid drops, particularly in the cicatricial phase of managing early trichiasis?
Yeah, so this has been proposed, and if you think about the pathogenesis of chlamydial infection and then the immune response in the body and then moving on to fibrous scarring, there would be a logic to suppress the inflammatory response and the fibrous scarring with steroids. A kind of logic in that sense. The issue really is, again, we're dealing with a public health problem, and one would not use steroids, topical steroids, in any way in a public health campaign. In the case of an individual, then of course the danger is in using it in an individual with severe inflammation, putting steroids in their eye. you're leaving them susceptible to other infections, particularly herpes simplex. And therefore, one would say probably the benefits of reducing the scarring are outweighed by the potential problems that you would get with steroids. Having said all that, I remember a case which I saw myself when I was working in Tanzania, which was actually an adult who came with severe bilateral pannus, right? So a real kind of acute and invasive of the cornea pannus, which I believed was due to trachoma,
right.
And was really threatening his vision in the acute stage. And I treated him with topical tetracycline because that's what we had at that time. I think I also gave him doxycycline, the systemic thing. And in a hospital situation, I did put some steroids in his eye, but that's anecdotal. Whether it helped or not, I don't know. And certainly I would say it's not something that is to be recommended.
I think it sort of highlights the decision making that has to happen at a clinical level and what policy and guidance you need to prepare for public health.
Yeah.
And, you know, the logistics of the two. Of course, the role of the clinician will always remain, and like you've shown that sometimes you do need to make that decision.
I feel it might be right.
It might be right in that scenario, but in the public health, we cannot give out steroids in a free way.
No.
So I think that was a point that was raised by Rosalind Schultz in Alice Springs in Australia for this course. So it seems to be still remaining as a problem to try and get both our experts from these far and wide places together. Just to keep us going on the topics that we can still cover.
Yep.
We've got a few questions here regarding mapping and the use of trachoma action plans. Shall we go on to those questions? So one of the questions that's been raised, after you've finished doing the mapping exercise, how soon after that do you need to develop, or can you realistically develop the national plan and put that into place? And what is the timeline, and what are the challenges and the potential to then reach that 2020 target that we want for elimination?
So, I mean, this is a very important question, and it's not that there's one right answer. I mean, it can vary from place to place, but really, the mapping exercise itself should already be part of a national plan, because the national plan should be saying, we believe that we have a trachoma problem in this country, we need a plan to address it, and the first question in that plan is, which are the endemic districts in the country where we need to focus the safe strategy. So in that sense, the first action in a national plan is the mapping process. And the mapping should be done at district level. And now, particularly in the last 4 to 5 years, there's been a huge mapping project around the world, which was led by Anthony Solomon. And I think most countries, the maps are now available. There are some where work still needs to be done, but for most countries, it's now known these are the endemic districts and these other districts are clear. So once that mapping is known, once you know, okay, in our country, there's 20 districts and 10 of them have got endemic trachoma, then as soon as possible, one wants to implement the safe strategy. And to be honest, sometimes the safe strategy has even started before the mapping process because it was just known that this is a very bad area. So as soon as possible, one wants to start on implementing the safe strategy. And for that, that's where what's called the Trachoma Action Plan comes in, the TAP, which is to really look at what are we going to do about surgery, what are we going to do about MDA for azithromycin, and what are we doing about F and E in terms of personal hygiene, health education, water and sanitation. And that is done district by district. So you may not be able to start everywhere at once. You may want to prioritise the worst districts and start in those. But certainly the S and the A should be going and closely, quickly backed up with the F and E components, with a plan of, we're going to start in these 3 districts, and from the learnings in those 3 districts, we're then going to expand to the next 7. Yeah. Just in terms of the longer term time frame, when it comes to MDA, if you have districts where the prevalence of TF, trachoma follicular trachoma, in children 1 to 9 is more than 30%, you will need at least 5 rounds of MDA. Whereas if it's less than 30% but more than 10, you'll need 3 rounds. So naturally, once you've done the mapping, you want to start with those districts that have the higher prevalence, because they are going to need the more years of the SAFE strategy.
Mm. That's right.
It's very funny using the Google Hangout to say something and then not say, are there any questions? I'm sure there are lots of questions online.
So this is an interesting question that's been raised on TAPs, and it's a practical one, where they say TAPs have to be owned by national programs. Yeah. The challenge in many places is that this is often the stumbling block, where certainly there's not enough guidance or leadership in place at that national level to get the process moving or keep it moving. So in our course, we certainly demonstrated how well it worked in Kenya. And because they have a strong leadership, they've been able to manage that process and keep the momentum going. So many of our participants have raised this. So how does one overcome the challenges of leadership when trying to roll out a good TAP?
So first of all, leadership is critical. And I think many people will say, if you look at the good programs around the world, you can often say, that national program is good because of that person who's been a leader and developed it and so on. But there is another side to this, which is also, it does relate to structure within the Ministry of Health. So historically, trachoma programs were usually part of National Prevention of Blindness programs. So they came under eye care. And usually eye care within a Ministry of Health was led by an ophthalmologist. And so there would be the National Prevention of Blindness coordinator, an ophthalmologist, hopefully a committee with that person and working with the government. And within the framework of the blindness program, one could embed the trachoma control program and the TAP, the trachoma action plan. However, over the last probably 5 years or so, there have been changes, and increasingly now, trachoma comes within the remit of neglected tropical diseases. And very often now within ministries of health, there will be a focal person for neglected tropical diseases in that country. And within that, their mandate will be trachoma. And that then is the leadership through which to work. And for example, if you're an eye care worker, an ophthalmologist interested in blindness prevention in the country, you want to then work with the NTD program to look at how trachoma is integrated within the NTD program of the country. So it varies. Some countries are prevention of blindness and eye care leadership, others are NTDs. And of course, like you say, sometimes it falls in between. And one just has to try and push as well as possible and to find that advocate within the government who will kind of say, yes, I'm going to take this on and make sure it happens, and then work with that leadership.
Well, I certainly think that, have we got, oh, we have. Dr. Solomon, who is online. Excellent, thank you. Anthony, hello. Can you hear us? We're doing sign language right now. So we can't hear you. No, he's certainly saying something, but we can't. Have we got?
I think we carry on and then we'll try and get Sol joining us.
As we work on the audio side of it, we've got visual, but no audio now. So within the TAP programs, one of the things that has come up is certainly when trying to set up trichiasis programs, the issues that many people seem to be faced with is the lack of resources. And without the resources, they cannot deliver the services they require. So what are these challenges and how can these challenges be addressed in order to get to our elimination targets?
Okay. So obviously resources are critical. I think one has to say right at the beginning that generally the safe strategy, certainly S and A, add F to it as health education, that is a very cost-effective intervention. So one's not looking at huge amounts of money there to do the S and the A and the F, if one thinks of health generally. The E component, water and sanitation, particularly the hardware that goes with that, that's an expensive intervention. But let's just take an F and think about what the resources are that are required. And the first critical one is people. So are there people trained in trichiasis surgery to do the surgery? Are ophthalmic assistants available who can be trained? And again, that's relatively low cost to be able to do that. The A, obviously the drug is free of charge, it's a donation, but it's the distribution program.
Yeah.
If the distribution program again can be part of other distribution programs like NTBs, and that's lowering the cost, right? Because one can do several drug treatments at the same time. And within that, I'm going to doing that MDA. At the same time, you can do the health promotion, which is the F component. So just go to that. What may look as significant resources in actual practice are not very expensive. Probably the most important things are the cost of the instrument for the trichiasis, any outreach costs to either take the surgery to the villages or to take the MDA to the villages. Now, where is that money going to come from? Of course, ideally from the government. It should be a commitment by the government that this is part of their program. And I just go back to it, it's not a lot of money, but one needs to do it. If literally the government can't afford to do it, or if it's a question of getting some seed money in to get it started, then often there has been external donors that have been on this, be it NGOs or be it other international donors that have given money, USA, and the Queen Elizabeth Diamond Jubilee Trust have all given funding for safe implementation.
Hello, Dr. Solomon.
Hi, Dexter. Hi, Alan. Sorry about the delay.
No problem.
I can hear you now, and it sounds like you can hear me too, which is great.
Yes,
yeah, that's
excellent. Well, I'm going to let Alan start you off on a few questions that we've got lined up for you. Sure. So it's almost like an exam panel that you've got sitting here.
Great.
So just to let you know that we have we have over 2,600 participants from more than 100 countries that are involved in the MOOC at present. And once the recording goes out on YouTube, there will be a transcript also provided for those who can't get the audio to download.
Okay, great. Thank you.
So Sol, I've been quizzed for the last half an hour by Daksha. I won't ask you the same questions because you may give everybody different answers.
Sure. Very sensible.
Maybe just to start and to kind of warm things up, Sol, how did you get involved in trachoma work?
Well, it was you, Alan. As you probably remember, you gave us a lecture as part
David,
of the...
maybe.
Well, David was there as well, obviously, but you were the first person who I can recall ever hearing anything about trachoma from as part of the ophthalmology day on the Diploma in Tropical Medicine and Hygiene course in 1999. I think it's fair to say that changed my life in all sorts of useful ways.
So what was your first kind of field work with trachoma?
I was lucky enough to get involved in a project in northern Ghana, in which we worked with the Ghana Health Service to take a group of guinea worm volunteers to see if we could work with them to diagnose and treat trachoma with azithromycin. And that was in '99. That was just at the stage that Pfizer was warming up towards starting a donation program. They started the program to donate the drug to trachoma elimination programs in that year. And several people, including yourself, were looking for sensible ways to make the distribution possible. And the opportunity of having a program that was functioning well in the guinea worm program and that was functioning so well that it was starting to run out of cases was a really good idea. And as you probably remember, that was a successful trial that we did in Ghana and has led in part to Ghana's success in eliminating trachoma, which they seem to be very close to now.
Yeah. Sol, can you briefly just tell the people who are joining what your job and role is today? Sure.
As of the last 2 years, I'm responsible for the Global Trachoma Program at the World Health Organization in Geneva. So I'm based here with trying to provide support to trachoma endemic countries and their partners around the world.
Okay, thanks, Sol. So we've just been talking a little bit about national programs and trachoma action plans and kind of how some countries do that very well and other countries struggle. And I was giving a little bit the background that historically often trachoma control came under prevention of blindness, but more recently it's tended to come under neglected tropical diseases. Could you tell us a little bit now from the side of WHO, but also working with member states, with countries, where trachoma fits in terms of the NTD programs of countries and plans going forward?
Sure. Well, I think it's entirely up to countries in how they arrange things administratively. Responsibility for trachoma within WHO has moved from prevention of blindness to the neglected tropical disease department, but it doesn't have to be that way at national level. And whatever works administratively is the thing that should be taken forward, I think.
Good. So changing kind of topics quite a bit, you led the Global Trachoma Mapping Project. Can you update us on where that project is now? Quickly, kind of what has been achieved and what is still left to do?
You're cutting up in and out a little bit there, Alan. In terms of mapping, what's been achieved and what's still left to do?
Correct, that's right, yeah.
So the Global Trachoma Mapping Project started with the goal of completing the baseline trachoma map worldwide. We thought we had about 30 countries in which to work, and we ended up doing mapping in 29. We thought we had around 1,238 districts, I think it was, to map, and we ended up mapping 1,546 districts. So for the most part, the project, which ran over 3 years, fulfilled its mandate and a little bit more, but in the course of having conversations with health ministries about what needed to be mapped, which districts were suspected to be endemic, we discovered a lot more than we knew about at the beginning. And so there are still some districts that need mapping, either because they came into the conversation rather later, or because they were insecure at the time when we wanted to map them with the support of health ministries, and so they couldn't be done at that time. Trachoma is obviously not an emergency intervention, and collecting data about it is even less an emergency. So we took the view, and this was a view supported by health ministries, that putting field teams in danger because of insecurity was not something that we wanted to.
So Sol, if somebody joining us now wanted to know whether mapping is complete in their country and where the endemic districts are, how would they find that information out?
Well, the International Trachoma Initiative hosts a very nice resource called the Global Atlas of Trachoma, which is available online, and that has district by district prevalence category data for the whole world. And usually it also includes an indication of where districts are suspected to be endemic but don't yet have data. So that's, I guess, the first port of call. But you know, it's often the case that health ministries may have reason to suspect trachoma to be a problem in places, but they haven't yet necessarily had that categorization put on the atlas. So making sure that there's a conversation with the relevant ministry at national level is also often helpful. And that's a process of conversation that we continue.
Okay, good. So I'm changing topics away from mapping now to MDA. And with MDA, we've got this thing of 5 years and 3 years and 1 year, depending on what the prevalence of TF is.
Yes.
We've had a few questions regarding why do we recommend that? Is there any evidence for it? What's the rational reasons for why we say 5 years for this prevalence and 3 for that and 1 for this? Can you give us some background to that?
Sure. I guess it's mostly, sorry, I'm having to move because my battery's running low. I wasn't expecting to do this on the mobile. The evidence is in the form of programmatic experience mostly, rather than level evidence in a kind of randomized controlled trial format. To kind of definitively establish that 5 years was needed for a particular prevalence category and 3 years was needed for another, you would need quite a large randomized controlled trial with, you know, literally hundreds of communities and probably quite a lot of districts in quite a lot of countries. But the experience that's been accumulated over the last 17 years of the donation program from Pfizer suggests that the higher the prevalence of this inflammatory sign TF in 1 to 9 children, the more or the greater the duration of interventions that's needed in order to make a sustained impact. In other words, to bring the prevalence of TF down below the elimination threshold. The sort of most recent addition to that suite of guidance, the fact that for districts in which the prevalence is between 5 and 9.9%, that we should try 1 round. It's a quite recent addition to what we suggest to countries, and we're only just beginning to see the impact of that. And so far, it actually seems very positive. So sometimes that pragmatic approach of needing to make a recommendation in the absence of good evidence can still generate something that seems to work. And I think the Trachoma Expert Committee of ITI were particularly helpful in that regard. Under your leadership, Alan, in coming up with sensible suggestions that seem to be borne out in practice.
Okay, thanks, Sol. One question that's come in is the goal is elimination of trachoma, control of trachoma as a public health problem by the year 2020. maybe we should just make sure that we got the wording right there. But the question is, well, if a country's not achieved that by 2020, what will happen regarding MDA? Will the donation programme still be available? Will trachoma control be carrying on?
Yeah, I hope so. It's difficult to say, and perhaps it's more of a political question than a public health question. And well, politics is always fairly intricately intertwined with public health. But I think that so far, Pfizer has said that they're committed to the donation until 2020. Now, I think that if we manage to show substantial progress towards global trachoma elimination by the end of 2020, that there will be enthusiasm to continue to the public health endpoint. So I think it's my job and the job of others interested in seeing this thing done to get as far as we can, as quickly as we can, and to demonstrate that success in order to ensure that the political commitment is sustained beyond the date of 2020, if that's required. And it's certainly likely, based on the prevalence data that we have, that there will be a number of districts that will require surveys after 2020, and some of those districts are likely to require ongoing interventions after 2020. So this is a political challenge that we'll need to grapple with over the next few years. Having said all that, you know, there's, in my view, there's a real need to continue to kind of support the Get 2020 target in order that we maintain as much positive momentum as we can between now and 2020, so that we can achieve and document the success between now and then. So I don't yet want to back away from that target. I think the harder we push to try and achieve it, whilst realizing that it may not necessarily be 100% possible, the better it will be for the program as a whole.
Good, thanks. So I think I've got 3 more questions, and then we'll let you get back to your, what I'm sure is a very busy day, so.
It's fine.
And these are kind of fairly, if you like, general questions, but kind of give us all and the audience an understanding of what's going on. The first would be, as you look for the next 4 to 5 years up to 2020, what do you think are the biggest challenges that we face in elimination of trachoma by 2020?
Okay, I think number 1 would be issues related to trichiasis, and 2 in particular, what do we do about post-operative trichiasis? What do we do about lower lid trichiasis? What do we do about you know, those sort of more complicated surgical problems where there's not good access to ophthalmologists, or even better, good access to oculoplastic surgeons, because even fully trained medical ophthalmologists struggle a little bit with the problem of recurrent disease, and no one's quite sure as to how to deal with lower lid disease. And that's going to become an increasing problem as we as we scale up programs. You know, there'll be several 100,000 operations done in Ethiopia over the next 12 months if things go to plan. And in the best programs, one expects 10% recurrence or 10% post-operative trichiasis. So that's 20,000 people who will potentially need management by specialists who just don't exist at the present time. For trichiasis, case finding is another issue, how to manage that, and that becomes more and more difficult the lower the prevalence of disease becomes. So the job becomes harder the closer you get to the end point. For antibiotics, I think one of the principal problems is funds for distribution, and I think I came in to the conversation at a point where you were talking about some of the funding that's available, and talking about the need for increased domestic financing, which I absolutely support. And then on the F&E side, evidence for the critical things that work in F&E is a major challenge for the program. There's a clear need for programs to get involved in good quality operational research to better establish what needs to be done.
Okay, thank you. And then perhaps more on the positive side, what would you see are the encouraging things with regard to trachoma and, again, the future, not necessarily the achievements of the past, but going forward? Why should we be positive in our outlook?
Well, I suppose momentum and trajectory, and perhaps that's not what you wanted to hear, because that comes in part from looking at where we were 10 years ago, where we thought there were 8.2 million people who needed an operation for trichiasis, and now we think there are 3.2 million people who need that surgery. So the backlog's been reduced quite a lot, and the momentum is there, and the support is there. So the kind of global community of practice around trachoma is really energized at the moment to go on and get this done. So community and partnership, I think, is a real key. Along with that is a group of very committed donors who are involved in the partnership, who really want to see the work completed. I think we're getting better and better at being evidence-based in the program, and work that the London School's been involved in recently, looking at the best operation to do for trichiasis is a particularly encouraging thing. The ongoing commitment of Pfizer to donate the drug, I think, is wonderful. They would be the main things that I'd identify there.
Okay, and this is my last question, Sol. We, as Daksha mentioned before, it's been very encouraging that more than 2,600 people have registered for this course and are participating. What would be your message to those people?
Well, I'm extremely grateful to them for having taken the time, shown the interest to join the course. I think it's a tremendous time to be involved in trachoma elimination. I think we can do an enormous amount together. I think their participation in the course will hopefully help that. I would just like us all to work together as hard as possible for as long as possible to see as much progress as we can against trachoma in the next few years. And if there's anything that I can do to help that, then I'm here.
Thanks, Sol. If I can just add to that, as I mentioned right at the beginning of this, my first contact or exposure to trachoma was in 1975 in Tanzania. And if I think of what I saw and knew then and what I see and believe is happening now, I mean, it's just incredible the amount of progress that there has been. And you can say, well, that's 40 years, but I can assure you, I think one couldn't have dreamed 40 years ago where we are today. So I think realistically, yes, we all get worried about 2020, but I think certainly in the next decade, this disease, and hopefully before the next decade, but in the next few years, we are going to see this disease come under control around the world, which is a very positive thing. So Sol, thank you for joining with us. Thank you for your precious time. And thank you for all that you're doing at the World Health Organization to lead this global program. And my thanks to Daksha, who has put together the trachoma course and started off with this Google Hangout at this time. And Sally, who's our IT technician, sat across the table from me, who's been pulling her hair out, trying to get people online for the last hour. We hope you've enjoyed it. We're sorry for the technical problems that we've had, but it's been great, and we wish you all well. Thank you.
And we have apologies from Dr. Emerson, who is stuck in an airport somewhere near Johannesburg.
Okay, bye now.